Chapter 40 Common Physical Care Problems of the Older Adult. These are the theory objectives for this chapter. So these are 5 common physical care problems when we talk about our older adults that this chapter will discuss. Impaired mobility, alteration in elimination, alteration in nutrition, sensory deficits, and polypharmacy. And so those are some the 5 main things it'll talk about. But also, as you tend to get older, you may have some other chronic comorbidities such as arthritis or cardiac issues or things like that as well. Now, keep in mind too, just because you get older doesn't mean that you will necessarily have some of these things, but these are some common things that can occur as you begin to age. Okay, so let's start talking about mobility and aging. So as you begin to age, you might have some loss of calcium, some decrease in your bone density, um, decreased muscle mass, loss of joint flexibility. And so these things can increase your risk for falls as um, because of weakness or whatnot. So we gotta, put some things in place to prevent falls. But some other things that can contribute to our older individuals having mobility issues. Maybe they have things such as osteoporosis or arthritis, or maybe they've had a fall and had broken bones that uh, cause issues for them. Maybe they have cardiac or respiratory issues that also decrease their ability to be active and move around. Depression is an issue with our elderly patients. Neurologic disorders such as multiple sclerosis, all these things can cause patients to be immobile. And if you are immobile, then those other things can occur that and put you at risk for falls because you're going to be weak. So we want to encourage these individuals to make sure they're taking their medications appropriately. If it's calcium that they need, that they're taking their calcium. If it's arthritis, whatever they're taking for pain. So that they can be a little bit more mobile. So if we can get them exercising, doing range of motion exercise, doing low impact exercises or things like that, if we can get them to go on walks, that would be great as well. Um, and so, just, try to do some teaching with them as well on the benefits of trying to be a little bit more mobile and making sure they talk to their physician about any issues that they might be having. So, as we stated before, we want to educate our patients on the risks that occur with being immobile and the importance of them getting up, getting moving, being active as possible for as long as possible. If you can get them walking, if they're able to walk, have them walk for 20 to 30 minutes um, at least 3 times a week. Help them to increase their activities, get them, going to activities. If they are on bed rest, then doing some active or passive range of motion with those individuals. If they have arthritis, what kind of crafts and things that they can do so that they can ensure they keep up with their fine motor skills. So we want to, try to keep them moving as much as possible to prevent contractures, decrease that weakness, and whatnot. Okay, so we should be doing fall risk assessments on all of our patients so that we can identify any patients that might be at risk for falls. And if we do identify patients that are at risk for falls, then we want to put some things in place to prevent falls um, from occurring. First, we need to be assessing their medications, making sure there's no interactions with their medications that could possibly, or are there medications that they may be taking that could make them dizzy or things like that that could possibly put them at risk for falls. Making sure we educate them to change positions slowly so that they um, don't get dizzy or, you know, um, tip over, fall over, whatever. If we need a gait belt, use the gait belt. Like we said before, educating them about being active so that they can keep their mobility up. And because if if the more they become immobile, the weaker they're going to become, and then the more at risk for falls they will be. Um, if the person does have arthritis or osteoporosis, make sure we're treating that appropriately so that they, if they do have pain, we're managing their pain so that when they're walked, they're not in pain, um, which can, increase their risk for falls as well. Limit bed confinement because, again, all those things that we had talked about with immobility, if you're confined to the bed, um, that is immobile, and then that's going to put you at risk for becoming weaker. It doesn't take a whole lot for you to um, become weak. If you don't use it, you lose it. So we want to keep our mobility. So you don't use your legs, you lose the ability to use them. You don't use your arms, same thing. So we have to, try to keep them as active as possible. If they need assistive devices such as canes or walkers, make sure they have those available to them and make sure it's next to them. If they need a walker, then make sure it's close to them so when they get up, they can have it. It shouldn't be across the room from them. If you put the if they, put them in the bed or whatever, and then you put the walker over by the door, that's not helpful to them. Make sure the bed's in the lowest position. Make sure the call bell is within reach. Not only should the call bell be within reach, but you should answer those call lights in a timely manner because I've seen time and time again where patients have said I've been sitting here waiting for 45 minutes with my call light on because I need to go to the restroom and no one's coming. So then they attempted themselves to get up because they got tired of waiting and had a fall. So it does no use or no good to have that call light within reach if you're not answering them. So yes, have the call light within reach, but make sure you answer them in an appropriate time. Make sure you have your brakes on the wheelchair. Make sure it's locked, before you transition the patient anywhere because you don't want that wheelchair to move um, while you're trying to transfer them to, bed to wheelchair or vice versa. Make sure you have clear pathways in your rooms so that they don't trip over anything or no spills on the floor so, they don't slip and slide. Make sure it's good lighting so that if they do have to get up, they can um, see where they're going. Um, if the patient does have a fall, um, as the nurse, you want to make sure you assess your patient for any injuries before you move them. You want to also get their vital signs as well and get some help to, get them up. You're going to do your incident report. Now, remember, when you do incident reports, you're going to put them wherever your policy says put them. Most likely it's with risk management, but you're not going to put the incident report in the patient's chart. Um, you'll put it, with risk management or wherever your facility's policy says to put it. And then you will document in a chart about the incident, but you're not gonna make reference to the in the chart that you did the incident report. We're not gonna bring attention that you did the incident report. Notify your supervisor, notify the physician, notify the family about it as well. And making sure we're doing things to try to, prevent future falls um, from occurring, with these patients. Okay, so urinary incontinence is basically the inability to control your bladder emptying. So it's involuntary loss of urine. And so as you get older, a lot of things can contribute to having urinary incontinence, and mobility, which we just talked about, can contribute to that. Um, there's if they have altered sphincter controls for, whatever reason, maybe there's some type of neurologic disorder, maybe they had a stroke or something like that. Urinary tract infections put people at risk for incontinence or urinary retention as well. Um, the Also, like for men, if they have enlarged prostates, because the prostate surrounds the urethra, which will block urine from passing, but you might have dribbles of urine trying to get around that blockage, and so you'd have some leakage there. Uterine prolapse. Um, if you have diminished kidney function. So a lot of different things can affect the aging population and cause urinary incontinence. Also, another thing, like if you're when you're younger, if you're holding your bladder all the time, you're stretching that muscle out consistently. And so then that muscle tends to lose its tone. And when you get older, you can be at risk for um, urinary incontinence as well. And so, as the nurse, we want to make sure we're toileting that person every 2 hours. Um, Also, when you're toileting them, maybe you can turn on the water to try to promote urination. Sometimes the sound of that water um, stimulates the need to urinate. So toilet them every 2 hours. Make sure you're recording INOs. Um, Make sure if they're using leakage products like the pins or something like that, you're helping with that, and changing those appropriately. Provide privacy when you put them on the toilet. Some people don't like to urinate with people watching them, and things like that, and making sure you have them talking to the physician as needed. So, like I said, these are just other things that, we can do. Bladder retraining. So, like I said, if you're putting them on the toilet every 2 hours to get them trained um, on the urination, habit, time voiding if they're cognitively impaired um, patients. So, just getting them in the habit of going on the toilet. Important, we want to make sure we prevent skin breakdown. So if they are using incontinence products such as the pens or something like that, you want to make sure you're cleaning that urine off, not letting them sit in the urine, because a couple of things, just sitting in that urine increases their risk for urinary tract infections, and it also increases their risk for skin breakdown. So we want to make sure we clean that urine off with a mild soap and water, and not just letting it sit there. Easy release clothing, because uh, if they uh, have things they have to fumble with, and they gotta urinate, then and they're trying to fumble with these items, then they could, be incontinent on themselves because they can't release the unzip or unbutton the clothing that they might have on. If we said toilet, but maybe if they're bedbound, bedpan. Maybe they're using a bedpan. So making sure you're putting them on the bedpan, um, if needed, every 2 hours as well. Okay, so like we said, our elderly patients, when we talk about elimination, you have urine and bowel alteration and elimination. So also bowel, they're at risk for uh, constipation because, well, one, if they do have um, decreased mobility, that can put them at risk too, because decreased activity, as we stated before when we talked about promoting bowel elimination, you remember, put you at risk for um, constipation. But our elderly, they tend to lose fluid. They also, bowel mobility tends to decrease as well. If they're on bed rest, that puts them at risk. Pain medication, you remember pain medication increases your risk for constipation. A poor diet, so if you have low fiber diet, if you're not taking in enough fluids, you're not taking in enough fluids. And on top of that, we said our elderly patients have a decrease in their overall fluid. Those things put them at risk for um, constipation. Maybe they have some abdominal cramping or rectal pain. Maybe there's some abdominal distension. If they're passing small amounts of liquid stool, that could be an indication of constipation because they're trying to pass, the stool is trying to get around that blockage. So that could be an indication. So things we want to do, we want to increase their fiber intake, increase their fluid intake, try to get them moving, if we can. Um, start recording their bowel elimination. Maybe they need some stool softeners or some anti-diarrheals, a laxative or something like that. Um, and again, if we need to talk to the physician about something else, then make sure you do that as well. Okay, so if the constipation is not resolved, then an impaction um, can occur. And then it could possibly require manual removal of the stool because the patient might not be able to defecate on his or her own. Um, and so you want to things again to make sure we prevent constipation or fecal impaction, making sure they're drinking plenty of fluids. A normal healthy adult should be drinking at least 2,000 to 2,500 mLs a day. Again, if they can exercise, make sure the physician approves any exercise program that they might be on, but get them moving, exercise, walking, like we said, 20 to 30 minutes, at least 3 times a week if possible. Um, Also, prunes are good. Prune juice. Um, Fiber, increase their fiber intake. Raw fruits and vegetables are good sources for that. Um, Hot water or lemon juice first thing in the morning can be good for that as well. So, um, and I urge them heed the need to defecate. Remember, you don't want to, if you have to defecate, don't hold it because what did we say the colon does? The colon is absorbing fluid from the stool. So if you don't go when you have to go and you just allow it to continue to sit in the colon, then it's going to keep absorbing more and more fluid, which is going to make the stool harder and more difficult to pass. And the most common reason that elderly adults are institutionalized, the answer here is going to be number 4. So incontinence is the most common reason for elderly patients being institutionalized. And so incontinence is not a normal consequence of aging. So just because you get older, it doesn't necessarily mean you're going to be incontinent, but it's a condition that's secondary to other things that might be going on with the person. Okay, question 2. There are 3 behavioral approaches to urinary incontinence. Which of the following is not one of them? And so this answer is going to be 4. There is no intermittent retraining um, when you're using behavioral approaches for urinary incontinence. And so the 3 approaches that you will use are the bladder retraining, the prompted voiding, and the habit voiding. Okay, these are the theory objectives for the next section of this chapter. Okay, so our older adults have some challenges when we talk about nutrition. So although their energy and caloric needs decrease, when we're talking about our aging population, the need for certain nutrients does not decrease. And so remember that an individual can be overweight and malnourished at the same time. Thus, An elderly patient may need to monitor his or her caloric intake while at the same time ensuring the intake of required nutrients such as that they have the required nutrients such as the calcium and the iron. And so certain changes that occurred during this time period make it difficult for the elderly patients to achieve this goal. So for example, maybe they have a loss of teeth or poorly fitting dentures. They have a decreased ability to smell and taste food. Their appetite changes, maybe because of certain medications that they might be taking. Maybe they had decreased vision. Um, Maybe they have some chronic illnesses or chronic comorbidities. Also, keep in mind, many of our older adults have a limited income, and so and they may be socially isolated, which makes it difficult to get groceries or prepare meals or things like that. So, as nurses, we want to make sure the patient has proper fitting dentures, schedule them dental checkups if needed, or help them with that process. Make sure we provide healthy foods, even though taste and smell might have declined. Um, you want to have education sessions with them on what is proper nutrition. Um, make sure the patient sits in a proper position when they're eating. Um, Report any choking or swallowing problems that the patient might have. We might need to get PT involved. If they do have difficulty eating themselves, maybe they need you to assist them in eating, or maybe they just need a companion to sit with them while they're eating, or provide some encouragement. Um, you know, Make sure because make sure they're not pocketing food, or make sure especially if we got our dementia patients, reminding them to chew their food and things like that. Okay, so when we talk about sensory deficits with our elderly patients, vision may be an issue for some of our older adults, such as maybe they have issues with visual accommodation. And so they have a decrease in their ability to focus on near or far objects, um, because they have a weakening in their muscles that control the lenses. Or presbyopia may be another issue that's age related. And so that's a decreased ability to focus on near objects. So that might also be an issue for these individuals. Okay, these are some other visual issues that your aging patient may have. Glaucoma. Glaucoma is the accumulation of fluid inside the eye, and as a result, it exerts pressure onto the optic nerve, and so that increases difficulty seeing and eventually blindness, causing blindness in individuals. Cataracts, that's a clouding of the lens. Macular degeneration is gradually loss of acute central and color visions. So for these individuals, you want to make sure they have regular eye exams, make sure they have glasses that properly fit if need be. Um, Make sure they have their personal items within reach so they don't have to look for things. Um, if they are, do they need help contacting organizations to help with any visual deficits, or getting, things such as glasses or things like that. And talking to the physician, about any issues, helping them um, that they may have. Okay, so nursing interventions when you're caring for patients or elderly patients that are visually impaired. You want to make sure you orient the patient to any new environments that they may be entering, so that they know where things are and they can, maneuver around the environment easily. Use bright lights, remove any clutter or hazards that may be in the way so that they don't necessarily trip and fall over them. You want to identify yourself when you enter the room as well as when you exit the room, because patients need to know when somebody is coming in the room with them as well as when you leave. You don't want them talking, thinking someone's in the room with them and no one's in the room. So announce yourself when you enter and when you leave the room. Don't rearrange the patient's belongings. Um, Without their permission, because they know where things are. They know how to maneuver around. They know how to find things. So don't rearrange their things. Offer your arm for assistance when you're helping to guide a patient. Don't grab them and try to guide them that way. Just offer your arm for assistance. Um, and guide them in that manner. Sometimes using magnifiers can help with visually impaired. Large print books or audio books can be helpful for individuals that may be visually um, impaired. Um, Maybe you can help the person contact organizations that help with visual disturbances or things like that. Okay, so also some other sensory issues that might occur with our elderly patients. Hearing issues. They might have issues with hearing. Um, so like a hearing deficit where they can't hear, or presbycusis. That's the inability to hear high-pitched sounds and spoken words. Tinnitus. That's a ringing in the ears. A ringing in the ears that can lead to hearing loss as well. And so be cognizant. This can cause a lot of frustration for your patients. Sometimes they might also be embarrassed and don't want to admit it. So when we're talking to patients that have hearing impairments, you want to speak clearly and speak directly to the patient. You don't have to yell. You speak in a normal tone. You don't have to yell at them, but just speak clearly and directly. Also, face the patient, because a lot of times people with hearing impairments learn how to read lips. So, facing the patient when you're talking. Make sure they had their hearing exams. If they use a hearing aid, make sure they have their hearing aids. Make sure the hearing aids work. If they need batteries, make sure the batteries are working as well. Watch their expressions for any feedback. Maybe, you know, are they making faces as if they don't understand what you're saying or whatnot? If one sided is better hearing than the other, speak on the good side. Speak in the good ear if that's possible. Um, if they have glasses, make sure they wear those glasses as well, because same thing, like we said, face them, because same thing. Um, if they need glasses to read your lips, make sure they have their glasses on. Make sure there's not a lot of noise around when you're trying to talk to them. Sometimes people with hearing impairments, we might need, pencil and paper so that you can write things. That might be helpful as well when speaking to these individuals. Okay, so um, another common issue, sexuality. Now, just because a person gets older doesn't mean they have a decrease in their sexual desires. Um, it's just that a lot of different things can impact their sexual activity. Maybe they have a lot of chronic illnesses, chronic comorbidities, or things like that that prevent them from being active. Maybe their partner has passed away, or something like that. Um, Also, when we're talking about women, keep in mind they have a decrease in estrogen, which causes a thinning of the vaginal wall and causes dryness and painful intercourse. So you can educate your females that are having this issue, maybe to use a water-based lubricant to help with that. Different things like this can impact their sexual activity. It doesn't mean that their desire decreases. And so keep in mind, we still need to educate our patient. They may think because they can't get pregnant, they're, beyond the age of pregnancy or whatnot because of menopause or whatnot, they're still vulnerable for things such as HIV and different uh, sexually transmitted diseases. So they still need to practice safe sex for these reasons. And so we need to make sure we're educating our patients on this as well. Okay, so polypharmacy, our fifth issue when we're talking about physical problems of the elderly. Polypharmacy is the use of multiple medications. A lot of times this happens because, as we previously stated, some of our elderly patients have chronic comorbidities. And so as a result, maybe they have a primary care physician, then they have a endocrinologist, then they have a cardiologist, then they have um, other doctors involved as well. And each of these doctors may be prescribing a medication for that particular issue that they're dealing with and not realizing that they may be the primary care may have ordered some or another doctor may have ordered something that has a similar effect and not understanding this. So it's important every time you go to the physician, you take a list or take all of your meds with you so that they know what meds you're currently taking. Also can help what can help with this if you're using one pharmacist. And so the pharmacist can possibly catch some of these issues as well if you're using one pharmacist for all of your medication needs, and then they can, kind of try to catch some of that as well. Also, additionally, you have over-the-counter meds. Your older patients tend to use a lot of over-the-counter meds or herbal meds and vitamins and things like that. So we run into, polypharmacy with this. And so risk of this is you can have different drug interactions, even with when we're talking about over-the-counter meds or herbal meds or vitamins and things like that. We can still run into drug interactions and toxicity, which can cause behavioral and cognitive changes in our patient. And so also remember we talked about before with our older patients, they have a decrease in kidney function, a decrease in liver function, uh, um, decreased body fluid, decreased body mass sometimes. And so that prevents, with the decreased kidney function and liver function, that can decrease the ability of the drugs from excreting the body, which causes the drugs to be more concentrated in our older adult patients. So, um, all these things can impact our patient. And so we want to make sure we do medication reconciliations and really getting a great understanding of all the meds that our patient is taking and make sure they understand all the meds they're taking and why they're taking them and how they should properly be taking them. So again, this is reiterating some of the nursing interventions that we're going to try to do, for these individuals. A thorough medication history. When you do that thorough medication history, make sure your patient understands you need to know not only prescribed medications that they're taking, you need to know over-the-counter medications that they're taking, any herbal medications they may be taking, any vitamins they may be taking as well. So doing a thorough history and then eliminating any unnecessary medications. Like I said before, sometimes this doctor orders a med that is doing the same thing that another doctor may have ordered. Or sometimes patients go into the hospital and a doctor decreases meds that they were on or discontinues meds that they were on before. But when the person gets discharged from the hospital, they think they're supposed to resume it and then they continue resuming it. So making sure you educate them on what meds should be taking, why they're taking them, how they should be taking them, or whatnot. And like I said, making sure they're taking all their medications to the doctor with them or a list of all meds with them when they go so that the physician can see what they're on, and then using one pharmacist because the pharmacy can catch some of those um, issues as well. Make sure you do a comprehensive assessment on your patient so you can identify what their educational needs might be, and making sure the patient maintains therapeutic medication regimen. Okay. Question 4. What intervention would benefit a patient who has presbycusis? So the answer here is check to see if there is cerumen, um, cerumen accumulation. Cerumen is wax in the ears, because that can be presbycusis can be exacerbated by cerumen accumulation. Question 5. Next patient has a common aging eye disorder in which there is accumulation of fluids inside the eye that exerts pressure on the optic nerve. What condition does next patient have? So the answer here is going to be glaucoma. So remember, glaucoma is the accumulation of fluids inside the eye that puts pressure on the optic nerve. It eventually causes blindness also. And so a lot of times it might be asymptomatic. Maybe they don't have any symptoms or whatever. The first one is a decrease in the ability to focus on near objects. And then remember, cataracts are that's a clouding of the lenses. It's common. Cataracts can be common with diabetic patients too. Macular degeneration is a loss of acute central and color vision. And so it's not really a way of stopping macular degeneration.